What do you typically recommend for your patients, or how do you typically diagnose, high blood pressure? And I love that you're saying that, normal blood pressure is 120 over 80, because that's really the key, right? It's not anything above that shows there's a higher risk for cardiovascular disease. So how do you think about this in practice, and what do you do with your patients?
Right. And hypertension is still the number one risk factor for developing vascular disease. And it's called the silent killer for a reason, because most people aren't going to be aware that it's elevated unless it's checked and looked at properly. There's a device called the BioBeat. It looks more kind of like a Holter monitor that sticks over your chest, and it's looking at pulse wave velocity, and it gets calibrated and assess what your non-invasive blood pressure would be. And so you have this very nice graph over 24 hours of what that person's blood pressure is. And then you really want to see, does their blood pressure drop while they sleep? Your systolic blood pressure should drop at least 10% while you sleep. As cortisol levels should be going low. If your blood pressure stays stable, or at worst increases, that really increases the risk of a cardiovascular event, a stroke or heart attack, these plaques rupturing during these high shear stress events. And often it's kind of a telltale too, is that if you see a blood pressure that's static, often they're going to have some type of sleep disruptance. They have sleep apnea or something else that's driving their cortisol levels to be high while they should be recovering.
Welcome back to the Smarter Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Sherr, and it's a pleasure to be back with all of you. Today, I had the opportunity to actually interview an integrative cardiologist. There's very few of them out in the world, ladies and gentlemen, Dr. Michael Twyman. And here's a bio for Michael. He is a heart attack prevention expert, the founder of Apollo Cardiology, and a board-certified cardiologist. He's a decorated veteran. He served in the military corps as a physician in the Navy and was appointed department head of the Internal Medicine Naval Hospital Buford while simultaneously earning his MBA. Following his military career, he continued his path in cardiovascular medicine, which led him back to his hometown in St. Louis. After several years in a hospital setting, Dr. Twyman recognized his passion for prevention. He now integrates the best of both conventional and functional medicine to get to the root cause of his patients' cardiovascular issues. He serves as a role of cardiovascular director of the Institute of Muscle-Centric Medicine and is faculty member of the Quantum Biology Collective. Dr. Twyman is recognized nationally as a speaker in the areas of cardiovascular risk reduction, mitochondrial health, and circadian biology, known as both Mito Mike and Red Light Doc, and you'll see him with his glasses during our conversation. He is a highly sought after podcast guest, featured in 30 podcasts, over many more than that at this point. Dr. Gabrielle Lyons, a mutual friend, Mind Body Green, and many others. He works with multiple different types of people all over the world that come to his clinic, and I highly recommend you check him out. So Dr. Twyman and I had a really great conversation about multiple different topics all around cardiology. And what I was mostly interested in discussing was not so much the statin drugs and the Zedias and the other PCSK9s and things like that, although we did speak about those at the end. My conversation really revolved around understanding the endothelium, which is the lining of our blood vessels, and the glycocalyx, which is what Dr. Twyman liked to call the force field. We used a lot of Star Wars analogies during this conversation. And we spoke about in detail the endothelium, the glycocalyx, what makes it strong, what makes it break down over time, how to test for it with various types of labs, including things like uric acid, as well as devices that he has in his office that he uses, and then various non-invasive ways of actually looking at blood pressure and how you actually can do that. We talked about lifestyle, diet, exercise, supplements, all related to the glycocalyx and the endothelium. We also spoke a decent amount about nitric oxide and how important this is as we go older, as we get older, and as we understand things like PPIs and other drugs will deplete this. He actually had a nice little equation, ED equals ED, which is erectile dysfunction equals endothelial dysfunction. And oftentimes this is related to nitric oxide. So in the end, we also spoke about advanced cardiac testing, including the Clearly test and CT angiogram. We did speak about statins, blood pressure management, light, cardiovascular disease, and much more. I really hope you enjoyed this episode with Dr. Michael Twyman. If you enjoy it, please like and subscribe below so you never miss a Smarter Not Harder episode. And enjoy. We'll see you next time. Hey, Michael, how are you?
Doing well. How are you today?
Great. Thanks for coming on the show. I appreciate your time this morning.
Appreciate the opportunity.
So I love your picture behind you. That is a beautiful looking mitochondria, I believe, right?
Yes, it is. My team didn't know what to get me for my birthday the other year, so they got a iron worker to sculpt this giant mitochondria that's bolted to my wall behind the patients.
And it's a topic of conversation, right?
Correct. Oh, for sure. I mean, I obviously all the photobiomodulation red light panels in the office, and I know we'll probably talk about methylene blue a little bit. So I always kind of point to the heart has a lot of mitochondria, so we got to really focus on this organelle inside your heart.
Yeah, absolutely. So let's start talking here about cardiology and what you are doing in clinical practice that's very different from another integrative cardiologist. There's very few really out of the box cardiologists out there, and you're one of the ones that I do trust and learn about and I listen to all the time. And so where I wanted to start today was, you have the mitochondria behind you. I can't not start with the mitochondria now. I was going to start a different place, but let's talk about the heart and the mitochondria. I know that there are a lot of places in the body where there's a high density of mitochondria, and the heart is one of them. How does the heart make energy? Because I know it's a little bit different than the rest of the places in the body. And tell us about the mitochondria in the heart that are different or special.
So obviously the heart never stops working. There's systole and there's diastole. And during diastole, it actually takes more ATP and energy to relax the heart than it does to squeeze. So that's why if you do an echocardiogram, you're often going to see these different stages of diastolic dysfunction as early signs of mitochondrial dysfunction. And it's my understanding that the heart is approximately by weight 1/3 mitochondria. And so the most energy dense organs tend to be the heart and brain. And that's where the majority of the chronic diseases are popping up. The fun fact for the trivia nerd is that the organ that has the most mitochondria is actually the ovaries. Apparently, it has 100,000 mitochondria per ovary cell, so you need a lot of energy to make a new life form. And so, I often talk to patients, that life is about energy. If the heart isn't making enough energy, it's like having a brownout in the heart, and you either develop systolic heart failure, diastolic heart failure, arrhythmias like atrial fibrillation. So, try and figure out what's breaking the mitochondria, and then supporting it to get back online.
Yes. And so that's a great point. People forget that the most mitochondria are actually in the ovaries. And so I talk about this all the time. There's a lot of mitochondria in your brain and your heart, your liver. And what Dr. Gabrielle Lyons, one of our friends, would also say is that don't forget, actually, it's your muscle tissue that has the most mitochondria because, of course, you need that reserve if you're going to go get chased by a lion in Africa. So, okay, well, from the mitochondria, obviously, are really important for energy production. And what I care about with my patients, and I know what you care about, is how well they're making energy in general. And as they're making energy, they're able to make energy for their brain, for their heart. And it's really important to remember that, of course, your heart's beating every moment of every day for many, how many beats per day? Like there's probably like some stats there, right? How many times are heartbeats a day?
If it's 60 to 100 beats per minute, multiplied by the time, but I think it's like 10,000 beats a day or something like that.
Yeah, it's pretty impressive. So let's go talk about the main lining of the blood vessels, the endothelium. So I wanted to talk to you about this because I think what a lot of people talk about on podcasts these days, and that you and I listen to, is that we're talking about drugs to prevent heart disease. Everybody's going to die of heart disease. Everybody needs to be on drugs. Maybe not everybody, but there's a lot of information out there that for almost everybody, at some point, you're going to need to be on one of these drugs. But before we get there, I think that the endothelium is really where I'd like to start, because that's where things tend to be the fuel for any fire. So let's talk about the endothelium and the glycocalyx, and tell us a little about those, Michael, and how you think about them and how you work with those in clinical practice with your patients.
Sure. And just a little bit of backstory is that, I did my conventional training in cardiology. I was an invasive cardiologist for many years, and I never gave it much thought about the endothelium. It was something I probably learned about in med school and kind of put in the back burner. But then when I started going down kind of the rabbit holes of integrative functional medicine, I realized how critically important nitric oxide was to the vascular system. And the endothelium, that's one of its main jobs, is to release nitric oxide. So the refresher is that the endothelium is one cell thick and lines the entire luminal surface of your blood vessels. And you have nearly 60,000 miles of blood vessels. So I was taught that if you were able to strip out all the endothelium in your arteries, that would be about the surface area of 6 tennis courts. So it's one of your largest organs that you don't know you actually have. And you can think of it sort of like the air traffic controller. The endothelium decides what stays in the lumen and what has access to the intimal side of the arterial wall. And if the endothelium gets impaired, that's the first step in developing atherosclerosis. And endothelial dysfunction can start in your teens and 20s. And if you intervene soon enough, then you basically stop that process. So I'm sure we'll talk about lipids. And I always tell people lipids are important, but it really starts first with endothelial dysfunction. So you have to look at how healthy is the arteries. And that's where, a lot of these non-invasive tests can tell you way before you're developing hard calcified plaques in your arteries. Are those arteries elastic? Is the pulse wave velocity normal? Are the nitric oxide levels normal on the arteries as well as your salivary pathways? So there's a lot of things that we can talk about today, but it always starts with the endothelium, and then some we'll get into is the endothelial glycocalyx, which is something that honestly 2 years ago, maybe 3 years ago, I never even heard of the word. And it's just something that it's becoming more critically important to understand that like the endothelium is first damaged when the glycocalyx gets damaged.
So let's talk about what the glycocalyx actually is, because this is a new word for me too, of course. I think for many of us, even obviously in the cardiology space. So what is it made of exactly, and where is it exactly?
So the glycocalyx lies over the endothelium. So think of it as like a protective gel coat. One analogy I often use with patients is, if you took a fish out of water and it's slimy, that's essentially what the glycocalyx of the fish is. And your arteries are lined with this protective gel coating. It has glycosaminoglycans and different proteins that are in it. And it's a place where there's different antioxidants. So superoxide dismutase is housed there. There's different anticoagulants that are housed there. So it's kind of like the ready to go system that like when the body needs to clot, it's able to clot if there's an injury. If there's, you're continuously breathing oxygen and you're going to be using that oxygen to combust the foodstuffs, there's always going to be reactive oxygen species made during that process. So there's a lot of antioxidants that are in the glycocalyx to prevent it from being damaged by that process. But if the glycocalyx gets damaged, then the lipoproteins, the white blood cells, they start sticking to the artery, kind of like Velcro, and then they can get retained into the intima and kick off the cascade that ultimately leads to plaque. But the glycocalyx, while very fragile, if you can get out of its way of what's damaging it, it often will be able to repair itself.
So it has regenerative properties itself.
Correct.
So let's talk about that. So what are certain things that we can do to optimize endothelial function and our glycocalyx function in general? Is from a clinical perspective, what are you telling your patients? We'll talk about the testing and we'll talk about, what causes damage. But I think, and maybe this is sort of the same conversation, like what is causing damage to these when we're in our 20s and 30s? And what are some of the things that we can do to try to help optimize that? I think you mentioned some of these, but I think it'd be great to go into a little bit more detail.
So yes, the two big broad categories, it's going to be high oxidative stress, high inflammation from any source, so gut related, infection. Obviously we just went through a pandemic a few years ago. The spike proteins from that virus directly can damage the endothelium. And so a lot of the long haul COVID symptoms are likely some form of endothelial dysfunction. And so there's, many things that can damage it. Smoking can damage it. A big one is high insulin, high glucose. So there's obviously a huge burden of chronic metabolic disease. And so there's infinite insults to the glycocalyx. And there's various tests you can kind of infer that, okay, the glycocalyx is probably down because the person now has high blood pressure. They have erectile dysfunction. They have, vascular disease showing up in other testing. It's like, okay, something happened to the protective force field. I often talk about that with patients. I think about the glycocalyx, the endothelium as being like the force field. If the force field's up, you're less likely to be doing damage to the arteries.
I like that. So you're using Star Wars analogies.
Oh, a lot of times, yes.
Do you have
use a lot of analogies?
No, I love that because when we're talking, I think what happens a lot of times when you're listening to podcasts and talking to people or listening to people talk, many of them aren't actually seeing patients. And so they don't have the ability to translate their knowledge to the general public to be generalizable, number one, but also understand like these finer points. So I love the idea that the glycocalyx is like this force field. And, I didn't realize actually until recently that the spike protein was a significant damager of the glycocalyx. Is it both damaging the glycocalyx and the endothelial lining together, or is it mostly?
Correct. Yeah, it damages the glycocalyx and then it gets access to the ACE receptors in the endothelium.
Wow. And is this something that you were seeing on the acute side as well, or is it something that we're seeing in more the chronic long haulers, or is it both?
It was both. At the time that COVID really kicked off, I was already all outpatient focused, so I wasn't seeing the real sick ones in ICU anymore. But that was sort of the evidence is that a lot of the hypoxia was that it was the microvascular system to the lungs that was getting impacted, and that's why they were such ending up on ECMO and things like that.
Yeah, crazy. Yeah, I was in the hospital at points actually in the beginning of the pandemic and throughout, and yeah, it was. Just a terrible time for a lot of different reasons. But what I've been seeing now is in the long hauler place is just this chronic inflammatory mitochondrial stress. And, I didn't really think about it from a endothelial perspective, but it makes a lot of sense as you're describing it. So, you were talking about oxidative stress as being having a significant impact on endothelial lining and the glycocalyx. How do you think about oxidative stress in your patients? Obviously you're thinking about it from the things that you mentioned, from smoking, from insulin resistance. Are there other tests that you're going to be looking at to look and sort of understand their oxidative load, their inflammatory load, and try to understand non-invasively, because we'll talk about some additional testing you can do and some of the other tests. But from a laboratory perspective, what are the certain tests that you're looking at to understand glycocalyx and endothelial function?
So I often talk to patients that, I think about oxidative stress, in the most part, being generated a lot by the mitochondria. The mitochondria are engines and they're burning that food stuff, but there's always going to be smoke combustion during that process. And so if you don't have enough oxidative support, other proteins in the mitochondria itself, the DNA will get damaged with that high oxidative stress. Some of the kind of quick labs that you can check is, the person's GGT level. If their GGT levels are high, they likely have very low glutathione levels. There's a urine test called F2-isoprostanes that you can get a ratio of it over your creatinine, kind of like the urine microbiome creatinine. But that F2-isoprostane test is a good surrogate for how much oxidative defenses your body has. So I always do at least those two to kind of do a quick check on oxidative markers, and then then there's all sorts of kind of various downstream effects where you can look at what are the arteries actually doing.
Do you look at levels of something like uric acid, for example?
Sure. Yeah, I look at uric acid levels because if uric acid is elevated, it's often a marker that the person has poor metabolism of fructose or alcohol, or they're just not consume, or they're consuming a lot of protein, but their body's just having a hard time kind of metabolizing it. But everybody thinks about uric acid being a marker of gout, which it is, but at lower levels, it's going to be directly injurious to the glycocalyx. It's going to cause a lot of oxidative stress to the gel coat, and then basically things start sticking to the artery walls.
Yeah, one of the things that we look at least in the practice that we have, since we have a nonprofit organization called Health Optimization Medicine in Practice, and we do education. And one of the things that we'll often do is look at urine and blood levels of antioxidants directly, or looking at levels of oxidative stress markers like 8-hydroxydeoxyguanosine, or looking at lipid peroxidase. These are probably not routine in your testing. I would imagine you're looking at other sort of corollary
Not
markers.
those ones exactly, but I do also check, oxidized LDL, which is not a great marker for vascular health, but it's a starting point. But there's a lab called oxidized phospholipid APOB. Now, if your phospholipids are oxidizing, then you got like a 5-alarm fire basically going on in your arteries.
Interesting. And so you're looking at inflammatory markers too, I would imagine, like CRP and homocysteine.
Correct, like high sensitivity CRP, LPPLA2, or that's also known as the plaque test. If that level is elevated, it often means that you have intimal inflammation. Myeloperoxidase, if your myeloperoxidase levels are high, often you're going to have some level of HDL dysfunction. So there's no such thing as good cholesterol. There's just cholesterol. But if your HDL is high and you have high myeloperoxidase, it's often a sign that your HDL is dysfunctional and actually is not doing anything that's useful to the body.
Interesting. Okay, so we'll get back to cholesterol in a minute, because I think that's an important piece. But before we get there, on the testing side of things, on testing the endothelium, testing for the glycocalyx, not lab testing, but imaging, other modalities, how else do you assess function here? Did you hear the question, Michael?
Sorry, no, I think I had to pause for just a moment.
That's okay. No, so other than the laboratory testing, as we're describing, what other testing are you using from a non-invasive perspective to understand endothelial function, the glycocalyx, as far as imaging, et cetera?
Sure. So, as a patient would come into our practice, we'll first test their enterosalivary pathways. So there's the little kind of look like dipsticks. You put saliva on them, and the brighter red they are, the more nitric oxide that pathway is likely able to make. And then looking non-invasively, there's devices that can look at pulse wave velocity. They often look kind of like a pulse oximeter, and they will look at how elastic the arteries are. So as the blood's leaving the heart, it goes into those arteries. And if your arteries are healthy, it'll be like an accordion, and it'll expand and snap back very quickly. So the lower the score, the more elastic the arteries. If your arteries are stiff, you got to figure out what's causing the stiffness. There's a device called the Endopat, which looks at peripheral arterial tone. There's basically 2 probes you have on your fingers, and it's measuring the flow in your fingertips. There's a 5-minute run-in period where you're basically just making sure that the device is calibrated. There's a 5-minute period where there's occlusion of the blood flow in the brachial artery on one side. Your blood pressure cuff is pumped up over your systolic pressure, and often that person's hand goes numb for a few minutes. The other arm acts as the control, and after 5 minutes, you open up the stopcock. The blood rushes back in, and you get reactive hyperemia. So the blood rushes back in, goes over the glycocalyx, that transduces the message to the endothelium, like, hey, here comes a big slug of blood. The endothelium pumps out nitric oxide. The smooth muscle in the artery wall relaxes, and the flow of the blood rushes back down to your hand, and your hand wakes up. And then the device calculates a score known as your reactive hyperemia index, essentially the percentage of how much your arteries dilate when there's this vascular stressor. And your arteries should generally at least double in size, but optimal is tripling or quadrupling in size. So if it's less than 2, you have evidence of endothelial dysfunction. I kind of joke that your force fields are down. We got to figure out why the force field's down and try to fix this process.
Great. Well, those are really great tests for people to know about it. Are there any other cardiologists that are using those in clinical practice, or is it pretty hard to find those?
The pulse wave velocity, that's a pretty routine one that many places are offering. The independent's a little bit more challenging. There's a lot of data out of the Mayo Clinic that correlated this device against invasive acetylcholine testing. So that's why I kind of stick with this particular device. One thing I did mention is, the tried and true, just free way is, what is your blood pressure? Your blood pressure should be less than 120/80. Optimal is 110/70 without medications. And so if your blood pressure is elevated, that's often a sign of endothelial dysfunction. We have a novel device that will assess central aortic blood pressures. And it's essentially a device that's listening to, how fast the blood is being reflected from the iliac arteries. So the heart keeps pumping out, 60 beats a minute. That blood's going to go down into the lower extremities, bounce off the aorta bifurcation, and the blood flow, the water, comes back. And so kind of like splashing water at a wall, it comes back at you. This device can measure how fast that reflection wave is, and it can infer what the blood pressure would be as it's coming out of the aorta. And tell the patients, well, that's the blood pressure that's going to be going down your coronary arteries or your carotid arteries. That's your true, systemic pressure that we want to be monitoring. And so it's going to be a little bit different than your brachial, but the brachial is a good starting point for people.
Gotcha. And so blood pressure is an interesting point. And I want to talk about that for a minute, because I think it's important for people to understand, as a clinician, how we are actually checking blood pressure. And you mentioned this, I think, just briefly. So how do you feel like the best way is for clinicians to check blood pressure overall? There's the one reading in the office when they come see you, probably not the best way to check blood pressure. What do you typically recommend for your patients, or how do you typically diagnose, high blood pressure? And I love that you're saying that, normal blood pressure is 120/80, because that's really the key, right? It's not anything above that shows there's a higher risk for cardiovascular disease. So how do you how do you think about this in practice, and what do you do with your patients?
Right. And hypertension is still the number one risk factor for developing vascular disease. And it's called the silent killer for a reason, because most people aren't going to be aware that it's elevated unless it's checked and looked at properly. I often get patients come into my office and their blood pressure is elevated, and they're like, it's never this high. It's white coat hypertension, or it's just when I'm at the doctor. I'm like, possibly. But, if we corroborate with the other information, like your arteries seem pretty stiff, the nitric oxide testing is down. Like, I bet your blood pressure is not high just today. And so in the office, we check the blood pressure the proper way. We have the patient seated, feet on the ground, their back is supported. We try to let them rest for as much as possible, because often, if somebody just runs in from the parking lot, plops down on the chair and check a blood pressure, it's going to be a little bit higher, because when you exercise, your blood pressure is supposed to go up. So you want to be in a rested position. So at home, if you're doing this, do it first thing in the morning before you have any caffeine, nicotine in you or anything like that. Sit down, put your feet on the ground, have your back supported, have your arm at heart level resting on a table or chair, and then you should be using a brachial blood pressure cuff, the one that goes over your bicep area. The ones that are over your wrist, sometimes are accurate, but often are not. I've seen them off 40 points high, 40 points low. So if you want to use a wrist one, the trick is bring it into your doctor's office and calibrate it against the device that they're using, and then see what your blood pressure is. And if the number doesn't make sense, wait 5 minutes and repeat it, and then kind of average it out. But again, your blood pressure should be trending 120/80 or less. And then in our office, if we see this pattern, we'll be doing the biomarkers and such, and seeing if they have high inflammation or high uric acid to figure out what's driving it. But if you really want to know what your blood pressure, you have to do a 24-hour blood pressure monitor. Right. And there's a couple different ways to do that. We have the old school ones that you have the tubes and there's a little battery pack and it buzzes. And I'm a pretty good biohacker. I do all this stuff for myself before I recommend patients do it, because how bothersome is this going to be? And it does wake you up a little bit while you're sleeping, but there's some novel ways to do it. There's a device called the BioBeat. It looks more kind of like a Holter monitor that sticks over your chest, and it's looking at pulse wave velocity, and it get calibrated and assess what your non-invasive blood pressure would be. And so you have this very nice graph over 24 hours of what that person's blood pressure is. And then you really want to see, does their blood pressure drop while they sleep? Your systolic blood pressure should drop at least 10% while you sleep. Because cortisol levels should be going low. If your blood pressure stays stable or at worst increases, that really increases the risk of a cardiovascular event, a stroke or heart attack, these plaques rupturing during these high shear stress events. And often it's kind of a telltale too, is that if you see a blood pressure that's static, often they're going to have some type of sleep disruptance. They have sleep apnea or something else that's driving their cortisol levels to be high while they should be recovering. So the 24-hour blood pressure monitor is really the gold standard to tell you, is your blood pressure normal or not? And people often will say like, well, my blood pressure is not that bad. It's like, well, the risk really starts increasing when it's greater than 110/70. And as a clinician, you're not supposed to use medicines to drive people down that low. They've never shown that using meds down there helps people. And you then kind of sometimes overshoot, obviously, in people when you're using meds. But if your natural blood pressure is, mine often is like 102/65. I'm not dizzy. I can exercise. And I'm not taking any meds to make it go down that low. So fine, my blood pressure is fine. But so that's what I tell people is like, whatever your blood pressure is, if you're not symptomatic at the low side, it's probably going to be okay. But if you're dizzy, you feel like you're not going to be able to like get up the stairs without holding on to something, then yeah, maybe they need to back off on your meds or your supplements that if you're kind of artificially lowering the blood pressure.
Yeah, no, that's a great point. I mean, I know that there's been some studies in stroke, for example, that like the lower you can get the blood pressure, the less risk they have of recurrent stroke. But again, that's always balancing the back and forth between becoming posturally hypotensive related to low blood pressure, which certainly happens a lot if you try to get it too low. But yeah, my blood pressure runs around that same as yours, Michael. And so I do know that you can have a normal blood pressure. And of course, a lot of women have blood pressures in the 90s or 100s systolic, and they do just fine overall. But I didn't know there was a new test, the one that you were mentioning on the chest, to do the 24-hour ambulatory blood pressure, because I always thought, like, how is anybody can ever tolerate like a cuff on their arm for 24 hours to be able to do that at the same time? It's just like it's going to affect your sleep. It's going to make you feel like you can't get any rest, and then your blood pressure is going to go up. But what I love what you're doing also is that it's not just about the blood pressure, right? You're getting a blood pressure reading in the office, but you're doing all these other tests to correlate whether somebody really does have evidence of endothelial dysfunction.
Correct. And we actually just got a new toy this week. We got a new device that can do ABIs, and it's checking toe blood pressures. It's checking, all these, and it's all wireless. So it's a really slick setup. So, if you find high blood pressure in any organ, you have an issue. So sometimes my practice isn't so skewed that I would see much claudication right now. More patients are worried with kind of the upper part of their body. But if you have, as a guy, if you used to have a lot of hair on your toes or in your shins and all of a sudden it starts disappearing, that's often a sign that the microcirculation to those hair follicles are impacted, and then the hair starts falling out. So if your legs are starting to get shiny, you probably need to get your heart checked out then.
Just like if your penis doesn't work, right?
That's exactly right. Yeah. ED equals ED. So if you have erectile dysfunction, you're very likely to have endothelial dysfunction.
Yes. And that's a big one for people. I mean, this is where guys will present, right? And I do worry about a lot of the newer companies out there that are doing direct to consumer, Viagra, for example, and other types of these drugs, because it's probably going to, unfortunately, make people think that they can take these drugs, but not actually look at the root cause of what's going on. I don't know how you feel about that.
No, that's a great kind of jumping off point, is that, oftentimes, as a cardiologist, patients aren't necessarily coming in talking about their sexual health, but it sometimes is like, if you ask the right questions, like on my intake form, I ask, like, do you use medicines like Viagra or Levitra? And I'm like, I'm not concerned that you take them, but it's one of those things where it's like, if you need it to perform, it's often an issue that you don't have enough nitric oxide coming into the funnel. And this is why sometimes these medicines don't always work for guys. I think it's reported like 50% of guys don't actually get any good response to these meds because they really have no nitric oxide coming into the system. The way the medications work is they block the degradation of the nitric oxide. So they just keep it around longer so the blood vessels of the penis stay dilated. So if you're direct to consuming drugs to treat a problem, yes, they're going to get better from a sexual standpoint, but you're missing the boat that it's kind of like the check engine light went on. Like there's probably something wrong with your vascular system and go look at it. I mean, yes, there's reasons why, people have, certain anxiety or depression, or there's certain medications treating those, you can have side effects. Or if you're on a beta blocker, that's the biggest side effect, that younger guys will experience, is being on a kind of a older school beta blocker can cause ED. If you're withdrawing the things and they still have this issue, you got to check out their heart, check out their carotids, make sure they're not developing endothelial dysfunction or plaque in their arteries.
Yeah. And so that's a big one for me too. I mean, I was looking at some recent studies on the use of Viagra to prevent dementia. There's some correlations there. Have you seen those studies about what's happening?
Yeah, I mean, I mostly like headlines and such,
Yeah.
and it makes sense because it's like,
Yes.
if you can get blood flow and oxygen into a tissue, then the mitochondria can make energy and the lights stay on. So I think
Right.
that's probably the best way to think about it. I mean,
Yep.
the funny part is that they were developing these drugs for like hypertension, pulmonary hypertension, and all the guys were reporting better erections, so they
Yep.
went down that pathway and said we're going to use it for this. But it always had a vascular health benefit.
Yeah. And so, I mean, that goes, I think, along to like the next area where I want to talk about it. So we talked about ways you can damage your glycocalyx, damage your endothelium, ways you can look at laboratory analysis to understand this damage, understand what the ramifications might be. We've talked about some of the testing that you can use. So what are the ways you can reverse some of this damage? What are the ways you can actually, so let's talk about, obviously diet, exercise a little bit. We can talk about those, and then supplementation as well, because I think there's a natural decline, as far as I understand, of nitric oxide as we get older too, no matter what we do. So there probably is maybe, and I'd love to hear your thought on this. Is there a reason to start supplementing with nitric oxide at some point in our life?
The short answer is probably yes. We were both just at the longevity conference in Las Vegas, and the more you hear it, the more you realize like the human body probably wasn't designed to live past 40 years, or at least well. And so we obviously have goals to live to 80, 90, 100. You're going to have to do some kind of support for the body at some stage, and thinking about nitric oxide optimization is key because without blood flow, the organs are going to start really kind of failing. And as you mentioned, generally about the age of 40, your nitric oxide pathways tend to slow down directly on the endothelium. The enzyme endothelial nitric oxide synthase basically doesn't crank as well. So the body's converting arginine to citrulline. You need a lot of cofactors to make that enzyme work, and eventually it just kind of slows down. Mm-hmm. So then the body kind of falls back on this oral pathway where if you have a healthy oral microbiome, then when you're eating your nitrate-rich foods, the beets and the greens, that bacteria will break down the nitrates, turn it into nitrites. You swallow the nitrites, and as long as you have stomach acid, eventually the reaction will happen where nitric oxide will be produced.
You need stomach acid, everybody.
Yeah, you need stomach acid. Yes. And so it's kind of like a two knockout issue. It's like if you have horrible oral microbiome because you're using antiseptic mouthwash and you're on a proton pump inhibitor and have no stomach acid, well, that pathway is going to be knocked out. And now you're 50 years old and your normal endothelial nitric oxide synthase enzyme is kind of slowing down. You got the double knockout. Then you start seeing the people have endothelial dysfunction or erectile performance issues or blood pressure. It just makes sense that both pathways are down. So often you can support both of them, get the nitric oxide levels back up, kind of like force fields are back up, and the things can start regressing or improving in the right direction.
So with nitric oxide, and what are the best ways that you see as trying to enhance that in the system? Do you think it's the best, obviously, we can talk about dietary sources. You talked a little bit about this already, supplement sources, et cetera. What are your kind of go-tos here?
So, always start with like, what can you remove? And so, like I just mentioned, like, you don't want to be disrupting the oral microbiome. We barely know anything about the gut microbiome, but the oral microbiome, I think we know even less.
Right.
There's actually companies working on it, and it should hopefully come out this year, where you actually be able to do an oral salivary test and know if you have the right nitrate-reducing bacteria in your saliva. And then they're working on certain probiotic gums to kind of try to repopulate the good guys.
That's very exciting.
You basically don't want to kill everything in your oral microbiome.
Yes.
So just to have minty, fresh breath, well, you don't know what you just killed. You have no idea. And so, brush, floss, see your dentist. I definitely recommend those things, but avoid the antiseptic mouthwashes.
Yeah.
And then,
Mike, something on that real quick. Isn't there something out there? Maybe this is more of a Nathan Bryan question, but I've heard of waiting to brush your teeth when you wake up in the morning. Is this correct? What have you heard about this as far as waiting to brush your teeth until at some period of time later for this?
I haven't heard of the actual timing. I mean, I'll have to kind of ask him or think about what the mechanism would be if there's more lingering time of the bacteria in the morning and the nitrates. Right. I have no idea.
Yeah, that's more of a Nathan Bryan question, but I just thought I've heard that recently from a friend of mine, and I meant to look into the literature, but I'll have to actually ask him about that specifically one and see.
Yeah, I'm sure there's some circadian rhythm biology type of thing or something like that.
That's a good point. Yeah. So continue. So you were talking about,
but you have to have a healthy oral microbiome, and there's companies developing testing for that. So that should be outcoming this year.
Yeah, very exciting.
And then you need stomach acid, and I'm not telling people to stop their proton pump inhibitors. I'm not, this is not direct medical advice, but if you have an ulcer, you've got H. pylori, cool, be on your proton pump inhibitor for the 4 to 6 weeks that your doctors are recommending. But if it's 6 years later and you're still on them, you have to ask your doctor, like, why am I still on this medication? And try to work on getting off these things. And then there are multiple different companies that are making, quote, nitric oxide promoting supplements, but they don't all work the same. So you definitely want to pick a company that has some clinical research behind it, and can give you some, hopefully, human evidence that their product actually works. This is not CME, but the companies I tend to use more of, I use a lot of Calroy's products. So they have a product called Vascular, that has not only the ability to improve nitric oxide, but something called hydrogen sulfide, which is a vasodilator as well. I often use some of Nathan's products. He's got one N101 or NO2U. They're similar products, and those are the oral disintegrating lozenges. You let them dissolve in the saliva. Nitric oxide is released when it dissolves. Then you swallow the products, and that some of the cofactors that are in that product help basically recouple that endothelial nitric oxide synthase enzyme. So then the body's natural production on the endothelial lining actually kicks back up. So, you get the nitric oxide boost when it dissolves, and it's helping your body make more on its own. So those are the two products I mostly use for nitric oxide.
And so clinically, you've seen these to be useful in the sense that you have patients that are coming in with evidence of nitric oxide depletion in various capacities, and then you're using them and you're seeing the difference. What do you see anything pretty quickly?
Yeah, generally, especially with the pulse wave velocity testing. So, within a couple of days, you can see them go from a stiff artery to a more elastic artery. And then over time, some of these have been shown to help actually lower blood pressure by about 10 points systolically and about 8 points diastolically. So work about as well as most antihypertensives will, a one solo medication. So not telling people to stop their meds and replace it with it, but often if you can support nitric oxide, you'll see about a lowering of, a blood pressure about equivalent to what one of the antihypertensive medications would do. And then we also look at tests that look at carotid endomedial thickness. So that's going to be a longer term finding, but often we see that at least the inflammation in the artery and the plaque isn't progressing once we've repleted them with nitric oxide.
Yeah, I love that. I mean, I think you're definitely straight on and right on in the sense that it's about taking out typically for people rather than adding in, at least initially. The PPIs are just such terrible drugs over the long term. We know they can give you a high risk of kidney problems, of dementia, of C. diff, or traveler's diarrhea as well if you're traveling, because you need stomach acid to break down that street food, ladies and gentlemen. Right. And but I guess the dementia risk is probably related to nitric oxide, right?
I would suspect it is, and also that you just can't break down proteins that well. You just don't repair as well. I think it's multifactorial, but it's likely a big nitric oxide depletion issue.
Yeah, so interesting. Yeah, because I just I get very interested in, what we call metabolomic testing, right? Looking at vitamins, minerals, nutrients, and cofactors, and looking at all these things. And then you want to have all the building blocks, the amino acids, like you said. You want to have like good arginine levels. But what I forgot until you mentioned it again is that your ability to convert these things, and all of our enzymes get lazy as we get older. I mean, we can try to optimize them. We can work on looking at testing and optimizing our arginine levels, for example. But that may not be good enough because we may not be able to actually even convert. A lot of these enzymes and the conversions require lots of cofactors like your B vitamins, your zinc, if you're insulin resistant, and all this kind of stuff. So it's so interesting to kind of put it all together. But I think what it comes down to is that you have a patient right in front of you. Like, what can you do now to help mitigate their risk, and what is their longer term benefit of doing some of these protocols? I don't know if that makes sense to you.
No, definitely. And sometimes it is simplistic. We just be like, we got to get more blood flow into the organs and get the waste out of the system, and then then we can get into the weeds about all the nutrition strategies that can optimize your longevity. But it's like, we got to get blood flow in here first. And so we kind of in our practice have a kind of like 4 big buckets. Of course we're going to be talking about their nutrition, but I often use that through a lens of circadian biology. I want people to be eating during daylight hours and eating seasonally and eating for their mitochondrial haplotype. I saw a gentleman the other day who had an L haplotype, so he has an equatorial type haplotype.
Sure.
Well, he's got very tightly coupled mitochondria. He's more prone to burn carbs that are made in high light environments. He's not a keto guy, a cold weather guy. So it's like, okay, that's why there's no perfect diet for everybody. It depends on what your mitochondria are going to be able to do with that energy and information. And then I often use the Boston Heart Lab panel to kind of look at different metrics of like how well they're absorbing fats, how well their, glucose markers are going to look, insulin resistance markers and such, and kind of say like, okay, well, this person seems metabolically healthy, or we got to really work on their metabolic health. Exercise, obviously I'm going to defer a little bit more to kind of like our colleague, Dr. Lyon, and her cohort of people who are experts at this. But exercise is extremely important because this is probably the anti-aging drug. And one of the major ways that it works is that that blood flow during exercise is going to be rushing across the glycocalyx and promoting more nitric oxide production. So the body just gets upregulated, says like, hey, he's going to keep running every single day. We probably should be ready to make more nitric oxide when he keeps doing this. And then the two things where I think people sometimes don't always put much attention initially is, the four pillars, is going to be your stress levels. I always tell people like stress is ubiquitous. We're all going to have stress, physical stress when you exercise and mental stress when you're, doing a podcast with somebody. But like, how well do you recover from that stress? Cortisol helps us stay alert and survive. But if you're stuck 24/7 in this high cortisol environment, the glycocalyx is going to get thrashed in that type of environment. And then the third big one, or I should say the fourth, is really your sleep. I mean, sleep is critical. And I usually actually start with that with people first. When they come here like, I want to switch from carnivore to paleo, or I want to do something like, how well do you sleep? And they're like, why are you asking me about sleep? I'm like, because your mitochondria repair when you sleep. And those are your engines that are going to break down those foodstuffs that you're going to eat the next day. So let's work on your sleep first, and then we can manage everything else. So I always start with those buckets, and then do the comprehensive blood work and say, okay, now this is what we're dealing with.
Yeah, I think sleep is definitely left out of the conversation in almost every aspect of medical care. I mean, one of the main ways that I'm sure you saw this, and I still see this in my limited amount in the hospital, is how little we let patients sleep when they're in the hospital. It's actually quite terrible, and it's almost as bad as the food, I would say.
Yeah, or the lighting.
Yeah, and that was a big. Actually, that's one of the things I wanted to ask you too. Is that obviously you're big on light and circadian rhythms, and in training circadian biology, et cetera. How do you discuss this with patients, and what do you think the sort of direct effect is on glycocalyx and endothelial function in general?
I mean, I think it helps, decrease some oxidative stress, and it just helps people generally sleep better.
Yeah.
And so that's where I start with it. But my quick story was that like, I just stumbled upon this on accident. I was, flying over to Asia, and I was like, man, this jet lag's gonna be horrendous. And then saw some articles that Asprey was talking about these blue blackened glasses, and just bought a pair and just wore them on the plane. And I looked insane because I had the, deep wraparound red ones, and it, looked like the Unabomber. And like,
yeah, you don't
so
want to look like
they're going to kick me out this plane,
Yeah.
But I made it to Asia, and I had some jet lag, but like really wasn't nearly as bad as I expected. I was like, that was crazy. Like, why did that work? And so enjoyed my trip to Asia. When I got back to St. Louis, I just started reading, and then found the work of Dr. Sachin Panda, Jack Cruz, and then started understanding like, oh, the circadian biology thing is probably pretty important. And so just as a kind of experiment, I have tried almost every one of the sleep trackers, and my sleep quality would always improve if I wore the glasses. So I was like, well, since sleep's so important, I'm going to keep doing it. And then pretty much anybody who's ever seen me on social media or in person, especially in Vegas, I always have these things on if I'm in public and not controlling the light environment. It's just kind of like what I do now.
I mean, do you feel, I've worked around with this too a little bit. One of the things I do consider is that if you're blocking enough blue light, it also affects your wakefulness. So I sometimes will not use blue light blockers like during the day at a conference, for example, when I'm at a booth, as opposed to obviously knowing that I'm, suffering on some level because of the crazy light. I mean, what's your sense of sort of wakefulness during the day using the blue blockers or the yellow, at least the yellow lenses that you're using?
No, for sure. And I think everybody has a little bit different sensitivity to it.
Right.
In an optimal day, I mean, I'm up before sunrise every day. I mean, circadian entrainment is really dialed in for myself. Like I'm up at the exact same time, 365. And so like, even if I travel to Vegas, I try to stay on my St. Louis schedule if I can, or I'll just sit by like 1 hour, but then get back as soon as I can. But the first really bright light that you should be seeing in the morning should be sunlight. The sun is going to be balanced with red and blue light. And then those melanopsin receptors in the back of the eye get hit by the blue photons, sends the signal to the supracosmatic nucleus, and the body's like, daytime, here's some cortisol. Go out there and hunt and gather and do what you need to do for the day.
Right.
So yes, there's definitely a component that blue light is alerting. And so that's the blue light that you want. And then it's not as bad to have artificial light earlier in the day to kind of wake you up, but it's like when the sun would be setting.
Right.
So the sun sets, those blue photons are not supposed to be hitting the melanopsin receptor anymore. So that is the critical time, is post sunset.
Right.
And everybody does have to play around with the different colors, because I'm wearing the ones that block about 40% of blue light, because I still need some blue photons to hit my brain to tell my body it's still daytime.
Yes.
But if I switch up to the red ones block 100% of blue light and most of the green spectrum. I will literally be unconscious within 30 minutes of putting those things on. I'm very sensitive to them. So I would only wear them when I got to be in bed in this time, or if I'm on a plane and I want to tell my brain it's midnight where I'm flying, then I'll wear the red ones. But I'm very sensitive. So
wow, that's
I tell people that
you
have to play around with, these type of glasses. And if they make you too tired, take them off for a while.
Yeah, I love that's an impressive hack for you to be able to know, okay, if I just put on these dark ones in 30 minutes, I'm done. I love that.
Correct. I'm out.
And that must be because you've just been trained and worked on your sleep circadian cycles and to such a significant degree. But I think what I wanted to mention here is that when your sleep's off, when your light is off, it's going to affect that big round-ish spherical organ that's behind you. And then that's Correct. Also going to have a significant effect on your endothelium, your glycocalyx, right? Oh, did you lose me?
Yeah, I did for 1 second.
Okay.
About the effects of the mitochondria.
Yeah. So the question was just basically, as a result of having the light exposures at the wrong times, as a result of not getting good sleep, you're obviously going to be affecting your mitochondrial function and your glycocalyx and your endothelium. So this is probably how you describe it to your patients, I would imagine.
Correct.
Yeah. Yeah. Cool. Okay. So you mentioned in sort of your buckets before, what you're looking at with your patients. And we've talked a lot about the glycocalyx and the endothelium. And this is a really important piece for, I think, the mainstay of most of us in clinical practice, because this is really, we can affect a lot of change, and we don't have to get into the weeds as much if we don't want to, like I don't, but I'm going to with you now on the cholesterol panel itself. So let's talk a little bit about the cholesterol panel. Let's talk about what you look at. Let's talk about what you care about. And in the context of that, I want to talk about, when drugs may be appropriate, when they may not be appropriate as well. And we can go into that.
Sure. And yeah, obviously this could be a 10-hour podcast
yes.
if people wanted it to be.
But we don't know.
I generally start with, the cholesterol debate is kind of like the diet wars. Like, it's interesting, but I always start first, you have to repair the glycocalyx and the endothelium first. It's the force field. If you get the force field up and it's working well, it should be able to repel a lot of these lipoproteins. Now, there's still chances the APOB particles are going to get in there, but not nearly as much. So always, in my mind, that's my first lens. But then if we're going to look at things, look at them properly. So the traditional cholesterol panel is not that good of a predictor of who's at high risk or not. Now, if you have familial hyperlipidemia and your total cholesterol is over 300 and your LDL cholesterol is over 190 milligrams per deciliter, okay, you very likely have familial hyperlipidemia. Go check the gene panels and figure out which gene's affecting it and treat that person as needed. But you also see, sometimes, I know we're going to talk a little bit about the quote lean mass hyperresponders. They had a normal lipid panel at some point in their life. They change up to this low fat, or I should say the low carb type diet, and they have this panel that their LDL cholesterol goes through the roof, and it looks like FH until you kind of do the testing. No, they don't actually have FH. So that's the only way I really use the traditional panel. I think a lot of people put a lot of faith in this, triglyceride and HDL ratio being low, and that it's guaranteed they're going to be metabolically healthy. Not really. I mean, the triglycerides, for the most part, yes, but the HDL, it's almost a meaningless metric. You have no idea what the HDL is actually doing. You have no idea if it's going into the arteries and doing reverse cholesterol transport. HDL has rules and, for the immune system. So you don't know if a high level or low level HDL is actually good or bad. So just basically don't look at too much right now. And then the advanced panels. So in my office, I always use examples. I always have tennis balls and show people these things. So I tell people that, cholesterol is a critical molecule. Without it, you're not going to be alive. But cholesterol is a waxy molecule that's not going to float in your liquid plasma. So the liver makes these lipoproteins, these lipid protein carriers. So the cholesterol, the triglycerides, the fat-soluble vitamins, the phospholipids, they all go inside this carrier. And then the liver pumps them out, sends them through the liquid blood vessels. And if the glycocalyx is healthy, these things just slide on by. Mm-hmm. And then whatever organ on the other side needs something, it binds to it, download what it needs, and then it's got to ship it back to the liver. And this is often where some of the problems go with patients, that their LDL receptors don't work that well, or they don't make very many of them. And so the LDL receptor's job is to grab the lipoprotein, pull it into the liver, the components get broken down, put it into the bile, and then it's supposed to leave the GI system, because that's the way that cholesterol leaves the body. But in approximately 20% of the population, people will hyperabsorb some of these sterols that their body's producing and send basically right back through the portal circulation. The liver's like, welcome back, makes another lipoprotein and ships it around the circuit again. So with a advanced lipid panel, you can basically count how many of these LDL particles people have. And then there's a protein that's on the outside of the tennis ball analogy, is that's what ApoB is. The ApoB is a structural protein that holds this thing together in a sphere, and it acts as a little ligand or key to bind into the different receptors. So they're very, very closely correlated, ApoB and LDL particle. Those are the two main numbers you need to look at on an advanced panel. Now, there are some people that are going to have lipoprotein little a, and that is important to know that if you have high levels of that increases your risk of vascular disease. But the majority of the particles are going to be these LDL particles. So think of them as like, cars on the highway. The more cars that you got, the more likely is there traffic jam. Or if you're visual, I like to show people tennis balls. You got a lot of these things floating through your blood vessels. There's just more risk that they're going to be interacting with that glycocalyx. Sometimes if your glycocalyx force field is down, you're going to do something about lowering the volume of these particles so there's less crashing into the artery wall.
Right.
And that's kind of where we start with, is just explaining what cholesterol is and how this, got around. Like, that statins should be in the water and, we shouldn't have any cholesterol in the body, or statins are absolute mitochondrial poisons and nobody should take them. That's just kind of like social media noise, people talking. It's like you have to explain what is going on in their system and then find what tool you need to do to support them.
I got it. And so with ApoB itself, I love how you describe it as sort of it's this outer part of the tennis ball, right? And so is it just picking up LDL particles, or is it picking up all the low density particles?
So the ApoB is on the outside of the LDL particles, the VLDLs, right, which are, basically big beach balls full of triglycerides. And often most people don't have a lot of VLDLs unless they're insulin resistant. Now, there are some genetic issues where some people have super high levels of VLDLs, and ultimately the VLDLs kind of like shrink down and become LDLs in those individuals. There's ILDLs, which those are very transient. And then the other class is the LPLAs, which is basically, think of it like an LDL, but it's got an extra little protein on it. That extra protein kind of looks like a corkscrew. That corkscrew kringle, it allows it to basically dig into the glycocalyx a little bit easier. And then that is one of the reasons they think it's a little bit more atherogenic, is that extra protein that's on the outside of it.
Interesting. Yeah, thank you for that. Because I know oftentimes you get these more complex panels, like the Boston panel, for example. You'll see all these other types of LDL particles, and I think that what you're saying, and I think this is what the general consensus seems to be, is that ApoB seems to be a great overall marker here. Do you agree that that's, obviously, and I'm 100% with you that like we care about the actual force fields, which I love. I'm going to start using that. Yeah. But in the sense of ApoB, is that really what you focus on as far as on the panel goes, or is there anything else like this is ApoB plus the LPB? You talked about the genetic markers too, but.
Right. Yeah. If people really can only look at one number, I will simplify, just look at your ApoB if you really want to. And then, we can go deeper into the weeds sometimes later with people when they're like, I want to know, do I got the big LDL particles or the small? I'm like, they're both important, but it tends to be that the people who have a lot of small LDLs, they're going to be insulin resistant. And you can find that on their other markers and treat their insulin resistance.
Got it.
And so it's a little bit of a myth that like, well, if you got the big fluffy LDLs, that's not a problem. It's like, you don't know that. They still can get into the arterial wall if the force fields are down.
Right.
And so if you use the test on the cholesterol balance test on the Boston Heart Lab panel, and I like to use this one often in patients who got lipid disorders, because it kind of helps guide you to understand like, why do they have it? Is it an issue with the liver that's just producing more cholesterol, so they got to pump out a lot more of these? Or is it an issue with the gut recycling them? So I'll give you this analogy I'm using with patients, and I think it makes sense, is that, think of a bathtub and it's going to overflow with water. To prevent the water from overflowing, you can do two main things. You can reach in there and turn off the faucet. Turning off the faucet would be like shutting down the cholesterol production in the liver. You don't want it to go to zero, but you would dial it back so you'd make less cholesterol in the liver, less lipoproteins. Or some people have an issue with the drain. The drain doesn't, let the water out of the system. So that's where the PCSK9 inhibitors help, is that you basically open up the drain to get the cholesterol into the GI system. So supplement-wise, berberine does have a little bit of a weak oral effect on PCSK9. If that doesn't work, then that's where Repatha, Praluent, and sclerin can be utilized. Get the water into the drain. And then if you got to make sure that the water makes it to the main sewer line, That's where ezetimibe works. Ezetimibe blocks the water from backing up into the bathtub. So I like the analogy. It's not perfect, but most patients, it tends to make sense to them. Like, this is why ezetimibe is going to work better for you versus statin, or you really should consider statins or bempedoic acid or somewhere where you're dialing the faucet back.
I love it. So basically 3 pathways that you're looking
Right.
at there, whether you're going to use a statin, whether you're using a PCSK9, or you're going to use Zetia, for example. And so
Right.
you can get a good sense of that from looking at this panel, it sounds like, and knowing which one might be best. I mean, in the sense of the statin debate, in the sense of your feeling of risks over the long term. Certainly, there's been studies showing there's increased diabetes risk using statins over the long term. There's been questionable studies related to dementia as well, maybe depending on the type of statin that they use. Do you have a certain statin that you'll go to and not go to others? I've heard people like stay away from lipid soluble, for example, things that'll go to the brain. I don't know if you have any comments there.
No. Yeah, I mean, generally, if patients are going to be on statins, I usually recommend they use rosuvastatin or pravastatin if they can't tolerate Rasuva. I mean, it potentially on that thought that they're not as going to cross the blood-brain barrier as much. But as for the kind of the blood sugar one, pravastatin really was the only one of the classes that didn't show any bump in their blood sugar. And that is a thing that sometimes patients who sit across from me, that's the big concern, is like they're going to become diabetic with the statin medications. And that's not really the case. It's that, the statins do have a weak effect on the mitochondria's ability to make energy. And that's probably why that blood sugar is increasing. But it's not enough that's going to tip you into frank diabetes. And sometimes it's, risk benefits, like you're lowering vascular inflammation, you're lowering, you're stabilizing plaque at the side effect that the blood sugar goes up a little bit. Well, could you change your diet? Could you do more resistance training? Or, do you need to go on metformin to kind of help the blood sugar? That's a lesser evil essentially than over on this side. And then the brain one, that's very real. And, and I've seen it on all classes of statins where some people will truly have brain fog. And there's nothing that you can really point to in their labs to say that they're going to be susceptible to that always. And so I always tell patients, like, they might not have talked about this in the randomized controlled trials, but, you're an individual. And if this isn't agreeing with you, I would not believe that, like, you just got to take it anyway, suck it up. Like, there's so many other tools that we can affect, the lipoproteins if we need to even go down that route. But the one trick is if you use the Boston panel is you can look at the desmosterol levels. And if the desmosterol levels, there's kind of like, I don't remember what the exact number would be, but it's all color coded. Like if the desmosterol levels are in the green zone, okay, you've not over statinized that person. But if that thing's all the way crushed all the way down, then back off the statin or use something else then.
Interesting. So you can actually dial down depending on what that level looks like. I haven't heard that
Correct.
before. And so then would that be a correlation you think, or have you seen a correlation in symptomatic things like brain fog, for example, or fatigue if you've crushed it down too low and you can kind of back off a little bit?
Either not on statin already, or if they are, I'm always checking that at the baseline and seeing where they're at. And if I see the desmosterol is already kind of crushed, I'll be like, we might back off on this and add ezetimibe, or we're going to add berberine to support the LD receptor. We'll do something else, still keep your ApoB particles down, but just lower the dose of the statin then.
So interesting. So yeah, that's cool. I didn't know that. That's really cool. You're able to do that and dial it in like that. Because we're using statins as well in oncological cases as well, right? So we know that statins have some sort of stability capacity. They have some sort of anti-inflammatory capacity. So there is reasons to use them, but I love that you're using it in much more of a comprehensive way and thinking about the risks and the benefits, and then talking to patients about brain fog, because that's a big one that I've seen over the years. And I'm not a cardiologist. I don't see all these hard patients on statins, but when I was in the hospital all the time, I would have to just ask patients, do you get brain fog? And then I would know, like, if they were on higher doses of statins, like atorvastatin 80, for example, like people like they're like, I can't think, doc. I'd be like, well, I wonder if it's because of this. So anyway, that's really helpful. But Michael, in corollary to this is, you're not, obviously, I know you're not doing this, is going immediately to statins and Zetia and there's all these other aspects. And one of the things I know you're looking at is some of this advanced testing on the sense of looking at plaques and plaque formation. Let's talk a little bit about that, because I think that'd be really interesting, additional to talk to about.
For sure, because like I always tell people, like, there's the statins are tools, zetimide's a tool, but what are the arteries doing? If the endothelium and the glycocalyx have been damaged, okay, how far down the pathway have they gone? And I kind of call it like a subway station. Like, do they first just have vascular inflammation? Well, you can pick that up on a carotid intimal medial thickness ultrasound. The intimal will be thicker because the lipoproteins are getting retained there. And much like if you sprain your ankle, it gets red hot and swollen, the intima starts getting swollen. Is these lipoproteins are getting retained, kind of like flypaper, and then the monocytes start gobbling it up like Pac-Man, and then these foam cells develop. You can assess if there's soft plaque in the carotid artery with that as well. a very good starting point test for most people, over the age of 40, but I would actually probably say down to 35 because I've seen some people younger now with really high calcium score tests. So maybe I'm a little bit gun shy on it, but, a calcium score test, a CT coronary calcium score test, your score should be 0 forever. It often is not, but after 40, 6 out of 10 people probably have a positive score. But just think about like, when does it pop positive? If it pops positive when you're 75 years old, okay, fine. But like I said earlier, I saw somebody, in their mid 30s and their score is already nearly 1400. Okay, that's a 5-alarm fire. We got to figure out what is going on with this guy. But so a calcium score test is a good tiebreaker for most time that, are you truly low risk? If your score is 0, you're low risk. If your score is not 0, well, it's somewhat graded. If it's over 400, it's high risk. Over 1,000, very high risk. And sometimes that's a good tiebreaker for the people who say, like, my doctor's recommending that I go on statin therapy. Well, if your calcium score is 0, that's probably a good sign that, like, well, your force field's been up, that you haven't developed significant plaque at this point. So maybe work harder on your lifestyle and nutrition and your supplements and just try to modulate your cholesterol that way. But if your calcium score is over 300, that's essentially a coronary artery disease equivalent. It's like the equivalent that you've already had a heart attack. They should be treated like secondary prevention at that point. And statins should be on the table unless they have not able to tolerate them, or, if it's just pure on, like, I just don't want to be on it. Okay, let's find another option that's agreeable that can modulate your ApoB, whatever that's going to be. And then the more kind of newer test, it's been out for a couple of years, is the using the Clearly software with a CT coronary angiogram. So the CT angiogram, requires an IV. You often need a beta blocker to slow the heart rate down so that, there's less motion artifact possible. They give you a nitrate to dilate your blood vessels, so they get the best pictures possible. And then they administer IV contrast, so you're going to have normal kidneys to make this test happen. And then, most people are thinking about the CT angiogram as looking for the degree of stenosis or blockage in the arteries, which is a good metric, but not the be-all end-all, because unless you're symptomatic, it doesn't really matter how much blockage you have in your arteries, because it's still going to increase your risk of having one of these plaques rupture and cause, myocardial infarction. So you want to know, do they have any amount of plaque, no matter how stenosed the artery actually is. But what the Clearly software does is that they take the CT angio images, they use AI to process it, and then voxel by voxel, they look at the lining of the artery walls. And sort of kind of like thinking about an iceberg below the ocean surface, they're able to quantify how much plaque is in the artery wall. And they'll give you a number called your total plaque volume. And so the lower your total plaque volume, the lower risk you are. But it will quantify the plaque into a bucket of hard plaque, which would get picked up on a calcium score test. But it will also quantify it into soft plaque. And it's that soft plaque that tends to be more the vulnerable plaque, the plaques that tend to go on to the point where they rupture. And so you want to quantify how much soft plaque they have. And then that's when you implement a plan to, okay, like, we got to get on top of this nitric oxide thing to, like, put the force field back up so they stop doing damage. If their lipoproteins are through the roof, probably should modulate them so that there's better timing, that the arteries can do reverse cholesterol transport and pull that cholesterol out of the artery. And then you can repeat the test of any of these type of tests, depending on timing, and see that the plaque is stopped progressing. And then hopefully over time, you can see the plaques regressing.
Yeah. So with the Clearly test, how often would you hypothetically want to repeat this, given you're doing CT angio with contrast, for example? I mean, are there ways for you to kind of get approximations between, and so you can extend the time that you're doing this?
That is such a great question. And I'm actually personally trying to juggle this question because I had my own personal Clearly scan just a little over 2 years ago.
Okay.
And I'm trying to figure out, like, well, when do I want to repeat it for myself?
Yeah.
I probably will repeat it this year, but clinically, how often would I recommend a patient actually do it? I probably would wait at least 3 years to let all the kind of the lifestyle, the supplements, and medications kind of go to work. And then also to minimize the medical radiation the person's going to get exposed to.
Right.
It's not a trivial amount of radiation. So I don't think people should be fearful of it, but it's not a test that you're going to want to do every single year because of the risk of long-term DNA breakage and cancers if you absorb a ton of ionizing radiation. And that's part of the reason why I stepped out of the cath lab, is that I knew I was going to be soaking up a lot of rays that I didn't want to be soaking up as I continued to age. Yeah,
I mean, you guys do wear your vest and everything else like that, but I'm sure it's not enough. I think, I'm sure it's more common for cardiologists to get cardiovascular disease that have been in the cath lab all the time, I bet.
Yeah, and cancers, brain cancers, prostate cancers, because it's areas where aren't getting as much radio shielding.
Yeah, so I mean, it's a risk versus benefit ratio here. I mean, it sounds like you'd be a proponent for most people to get some sort of CT angio and hypothetically a clearly on top of that between 35 and 45 years of age as sort of like a pre-screening kind of test.
That would be outstanding if people could get kind of a baseline screening at
Yeah.
that point and say, okay, you are truly in low risk. Keep doing what you're doing. Or, the person raises their hand. Oh, I am really high risk, and I don't want to go down the route of having a heart attack like my dad did at 52 years old.
Yeah.
And it's one of those cases where this is just my own personal clinical experience. I've been doing this test a little over 2.5 years. I've only seen two people. They're both relatively younger women with scores of 0 on the Clearly scan.
Okay.
I've never seen a man with a score of 0. I've seen some very low scores, but I think it's such a sensitive test that you will find soft plaque in almost everybody if you go looking for it.
Right. I remember looking back in medical school, and they showed us autopsy reports of 20-year-olds that were dying during Vietnam and World War II. And when they did the autopsies, they had plaques at that point too. So this is not a new scenario, but I think, and we know that this is when they're starting. So it's not surprising to me that you'd find that. But what I think is interesting about the Clearly is that you have these soft plaques, like you said, that are the ones that are going to potentially be the problem over the long term. And so you can watch and monitor these things. It seems to me like every 3 years would be reasonable, especially if you have like 2 or 3 years, especially if you have other approximations of tests looking at inflammatory markers, looking at oxidative stress, looking at nitric oxide. You have all these other, looking at blood pressure, like all these other ways of being like, okay, you've made these changes, and now we can see that. And we talk about the same thing in looking at vitamins, minerals, and nutrients. Like you don't want to check them every month. You want to check them 6 months, a year, because it's not going to be helpful to do it so soon. So it sounds like from a CT angio and Clearly perspective, what's the insurance coverage on this at this point?
Generally, it's not a covered service.
Yeah.
And it depends on what city you live in, how much the baseline CT coronary angiogram would be. Where I'm at, St. Louis, it's about $650 for the baseline CT angio. I've seen some places as low as like $300. I've seen places as high as $2,000 for the baseline image. And then Clearly is a $750 fee to have them use their AA software to do the interpretation.
And does that have to be a specific MRI or CT scanners or radiology facilities to be able to do that? Or can it be the images taken over to a Clearly site from wherever?
It's more the latter, but the best way, honestly, if people are interested in the Clearly is, just go to their website. They have like a location finder in there that you can put in your zip code and find a center that is near you. Not every center is, if they're listed on the website, they have the capability to do this. But if you go to a different center, most places are going to have, some of the higher quality 64 slices and above CT scanners. So as long as the images are high quality enough, they can be then burnt on a disk and sent to Clearly for analysis often. But you just have to have kind of like a stopgap that the Clearly people are like, oh yeah, we can take those images and upload them and look at them then.
Right, just to make sure before you go ahead and go get the radiation and the contrast. Yeah, correct. So I got that. Well, I think that's really important. And I mean, is there any other testing that you're thinking about that we haven't spoken about that would be interesting to anything coming off the new hot off the press that you're looking at and doing that people in the cardiology space have no idea, but you're on the leading edge as usual, Michael?
Yeah, there's one test, and they're not FDA cleared yet, so I won't speak of what their name is exactly, but they're actually looking at something where instead of looking at the electrical fields that come off the mitochondria, they're looking at the magnetic fields. So they're looking at magnetocardiography, MCG. And so they actually have a scanner where you get in it and you can actually see the magnetic fields as it comes off your body. And that is probably a more sensitive marker of ischemia than looking at the electrical activity. But I was looking at it as more of like a function of like, well, how healthy is the mitochondria?
Yeah.
And so I got it in the scanner just to see what it would be like. I was like, all right, this looks cool. Like this is the future, but it's not there yet, but I'm keeping my eye on it.
So looking at magnetic potential, so electromagnetic potential rather than just electrical potential.
Right.
That's super cool. Yeah, you're gonna have to tell me more about that afterwards. Yeah. I want to. Yeah, I love that. Well, I think this has been a really great sort of overview and some details significantly on some areas of what you're doing in cardiology practice. So I really appreciate the time, Michael. I do have one more question for you. It is a question we ask every guest at the end of our show, and it's a very simple one, and I think you're going to have a lot of great answers here, and I think they're going to be relatively simple because that's what this typically is. So the question is this: what are the 3 ways that we all can live smarter, not harder? And that's the name of the podcast. That's the name of our company, our umbrella company, because again, we want to do smart things and not have to work as hard all the time. Although I tell my kids they have to do hard things. And oh, by the way, I should also mention that my kids do wear blue blockers Whenever at night when we're watching TV after dinner, if that happens on the weekends, they're always wearing their blue blockers. They all look great around my house and on their various screens. But anyway, continue. What do you think? Yeah.
Sure. So if I had to only list three, the number one thing would be see every sunrise for the number of days you got left, because that is really the key to set your circadian rhythms. And so I try not to ever miss them. Two, hyper focus on getting high quality sleep. It's not super sexy to talk about sleep, but that is your superpower. Your brain is going to work so much better when you sleep well. And if you have kind of an energy focused type of kind of way that you look at the world, if you want your mitochondria to work well, you have to sleep well. So if you're not getting 7.5, 8 hours of sleep a night, figure out what's breaking it and fix it. And then the third thing would probably be, don't overthink it. There's so many things that we are not in control of. There's only so few things that we can actually do. So just control the things that you can control.
Yeah, I love that. I talk to my kids about that all the time. We don't like to go into the what if games and I can't believe this is going to happen, or what if this happens, or I'm going on this. And so the what if games and the controlling what you control is huge, Michael. So thank you for that. Where can people learn more about you, maybe become your patient or in your clinical practice? I don't know if you're just doing telemedicine these days or seeing people just in person. So tell me a little bit about that.
Well, first off, thank you for the opportunity to speak to your audience. It's outstanding whenever I get to talk about mitochondria and biohacking and all the things that are also interesting other than just clinical cardiology. So again, thank you. But if patients are interested in working with us, my practice is named Apollo Cardiology. Apollo was the sun god. He was also the father of Asclepius, the god of medicine. So it made sense that I named him after Apollo.
Indeed.
And we're located in St. Louis, Missouri. We do offer telemedicine for patients, but the first visit is in St. Louis because we have all the non-invasive toys here. And so we can get everything screened up in one day. It takes 2 hours for a patient from, they walk in our door to the time that they go out. We do all the fancy blood work, genetic testing if needed, and then all the follow-up visits can be remote. If patients are interested in kind of seeing what I'm doing online, I'm mostly on Instagram. I'm not like any means a big influencer there. I do some IG lives every Monday night at 6 p.m. Central Time, and usually just kind of answer questions for people. And a lot of them are going to be these type of topics. Why do you wear blue blockers? Tell me about red light therapy. Let's talk about sleep. And so I just answer the basic questions for people. So my handle on there is just Dr. Twyman on Instagram.
It's awesome, Michael. Thanks for all the content you put out and all the information, because like me and the hyperbaric space, it's a very lonely space when you're doing things, as the cardiology space is, when you're doing things that are not with the whole conventional side. I mean, I agree with you that all that stuff is necessary at times, but putting it in a larger context and having the ability to convey that to an audience is huge. So thank you for educating me and my audience today, and keep up the great work, man. I hope to see you at a conference soon.
Awesome. Thank you.
All right, have a great day. Thank you for listening to another episode of the Smarter and Harder podcast, where we give you 1 cent solutions to $64,000 questions. It's been a pleasure to be with you again. I really hope you got something out of this podcast with Dr. Twyman. It was a wealth of information on cardiology. We all have hearts. We all care about them, and our family members. Of course, there's a lot of information here to do from a prevention side that's much, much different than your conventional workup. Don't wait, get things checked out. Check out Michael Twyman's practice if you're in St. Louis, or you can go check his information out online, and he puts out a lot of great information. Don't forget to like and subscribe below, and we can't wait to see you for our next episode of the Smarter Harder podcast. Until next time.